Yes, we can hear you.
Thank you very much. I am Sarah Kenyanjui. I am a psychologist in Kenya, clinical counseling psychologist, specialized in chemical dependency, currently working in a hospital. I would like each and everyone to introduce yourself, please.
Good morning, everyone. Can you hear me?
Yes, we can.
My name is Celeste Richards. I'm a clinical psychologist in private practice for 12 years. I'm from SWAZILAnd, now called Eswatini in Southern Africa. I'm also a part-time lecturer for trauma counseling and theories of counseling. And I'm also director of a wellness company for employee assistance and overall organizational wellness.
Thank you. Sandra, please, would you mind to introduce yourself?
Okay. I am Sandra Cheruto, a clinical psychologist by profession. I work at a public hospital here in Kenya.
Okay, thank you. I can see V. V, kindly introduce yourself.
My name is Verena. I'm an assistant psychologist in England in an IAPT movement, which is for individuals with low to moderate depression and anxiety.
Thank you very much for joining today's meet. It's going to be short. We are going to use 30 minutes. And yeah, I'm going to pose questions to all of you. You're supposed to answer within the shortest time possible so that we can make it to 30 minutes. So I'd like each and everyone to describe how depression looks like. Maybe you've had a client with depression. Kindly describe how depression looks like.
Okay, I think it's important. Okay, carry on, B.
Oh, thank you. I spoke to a patient the other day and he described it as getting a brain fog, where they just can't think clearly and don't see anything good in their life.
Okay.
I think being in practice for 12 years, there's a range of different presentations that I've seen. Some very DSM typical that you can see clearly it's depression, even the words some of the clients use. But then also I think some people describe it as a deep dark hole, being under a wave that they can't come out of. And then one of the other descriptions people have given is to say that they feel like they're on a roller coaster swirling, but it's not a fun roller coaster and they can't get off.
Okay, thank you. So Sandra, would you mind to describe how depression looks like?
Okay, I can say it's the most common mental health condition, mostly found among women more than men.
Okay.
That's from my experience. And what I have noticed is for like the young adults, they mask it. It's difficult to pick it out because you talk with them, they'll be laughing, but when they like take their mind away from the reality, it's when you realize this person is depressed. But for older adults, it's easy to pick. For younger adults, they mask it a lot.
Okay. Yeah. Okay. Yeah. From my experience, what my clients have been describing depression as, they say they feel like they are in a dark room. They would want to see light, but they don't know how they can go get that light. But they feel within themselves that they really want to see that light, and they don't know how. So I would like each and everyone to describe how depression affects the client who has the depression and their family. Anyone would want to start?
Okay, so I think, okay, carry on, Sandra.
Okay, what I have noticed is majorly there is interference with either schooling or work, the occupation part. It really affects. Then also there is the issue of isolation. There's a lot of complaints from family members and also from friends that the person is withdrawing herself or himself, unlike prior times in life. And because of mostly I think it's because of the isolation now and the neglect of work, you'll find now the person will be told to resign from work because majorly they don't understand when a person has depression. They feel like neglecting or being lazy. Then that one will lead to financial difficulties. And for social isolation, the person will be like discriminated because others look at it like this one wants to show herself off. They don't understand that it's a condition which makes the person to isolate herself.
Okay, thank you, Sandra.
Yeah.
I think one of the things that, well, we know that it affects them holistically. However, I do recognize in a lot of my clients that there's certain areas where they can still function well. And that is almost because it's become a form of coping or an area where they have control, and then they divulge like very much into it. So it will affect overall functioning. I think we can recognize that. It generally people would also sometimes be more aggressive or more agitated. So obviously we know if you're in a relationship or you're with people like that, your relationships are going to be impacted in a negative way. Not necessarily only family, but friends, maybe if you go to a certain church or societies you're involved in, but your relationships are negatively impacted sometimes. Sometimes people become a little bit more needy, and so because they appear to not be functional, people then may call them lazy or that they're not contributing to the household. So overall impacts relationships, but I think, like I said earlier, it's important to note that there will sometimes be an area where a person can still function, whether it's work or whether it's a sports situation that they're engaged in, but there's sometimes an area where they do. Relationships, like I said, I think I answered that in what I said, are generally affected. People, family, friends sometimes feel helpless, they're sometimes confused, they sometimes don't know what the person needs, because sometimes the client themselves can't necessarily say what they need. They themselves don't always know. And I think also it can leave the family or the household in a little bit of a flux, because sometimes I think that person can change the atmosphere completely in the home by virtue of their struggle. So that's some of what I've seen with my clients.
Okay, thank you. V, would you like to add something?
I think it can pretty much affect all areas of your life. So you might not be able to sleep properly or eat properly, or eat too much or eat too much. And then you might have good days where you're feeling okay, but then the next day will be even harder.
Okay, thank you, V. Josephine and Marcy has joined us. Josephine, can you hear me?
Yes, I can hear you.
Yes, Josephine, we were talking about depression, how depression looks like, and how it affects people around the patient and the family members. Would you like to contribute?
Yeah, thank you, Sarah. And it's really it's nice seeing all of you.
Okay.
Yeah. Well, depression is a very serious issue because it seems to present in most of the mental health issues that we come across, whether it's bipolar or schizophrenia or BPD, that is a borderline personality disorder. You always find some signs of depression here and there. And since it also takes a lot of time for patients to realize that they're actually depressed, then it becomes a very serious issue as far as our practice is concerned. So you find that the patients are coming to us when when it is late. The intervention is done when it is late and they have taken time, and maybe the depression has graduated into some other conditions. Yeah.
Thank you so much, Josephine, for your contribution. Mercy, can you hear me? Mercy, can you hear me? Okay, it seems like we cannot get to Mercy. Now, I would like us to talk about what prevents people from coming out clear about their depression. You'll find that some patients with depression or some clients with depression would not come out clearly to the public to admit, like, I have depression. What stops them from, coming out about their depression? Anyone who wants to start?
Well, I think we all know. Carry on, Dee.
I think there's still a lot of stigma about mental health in general. So that might stop some people from coming out. Also, family backgrounds. So maybe they've grown up in a family where mental health isn't understood. So they're afraid to be judged.
Yeah.
Or they're just ashamed of feeling this way. Because for them, what I hear quite often is, I don't have a reason to feel like this, so why am I feeling like this? Yeah.
Thank you.
I think, like V has said, because of the stigma, it brings about a sense of shame.
Yeah.
And so people don't feel comfortable sharing it, but also because they themselves sometimes don't understand what's going on, number one. Number two, if they do understand, the people around them may not understand. And also, I think it's, when it comes to any form of mental health or mental illness, I should say, it never always presents the same way. One of the things I know that my clients will often say why they don't reach out for social support to their loved ones is because it's the same, today it's the same story for 2 weeks, and then it only changes for 2 days and it's back to the same for 2 weeks. Yeah. So it's a little bit, number one, there's an inconsistency that leaves the carers not too sure of what's going on, which then makes it difficult for the client. But then also, they sometimes just, like I said, the shame, and they just feel that they've been burdensome, saying much of the same thing all the time. So those are the reasons why I think generally they wouldn't. And also because sometimes there isn't help. I mean, we're all in different countries, but I know that for one of the reasons people just keep quiet is there's no resources. So I'm going to speak, and then what? And there's not enough education around the importance of social support. There's not enough education around mental health. So people sometimes will just keep quiet because they don't see the point.
Thank you. Sandra, would you want to contribute?
Yes, maybe I can add one. One is from the causes of depression, there are not good things to look at. For example, breaking of relationships, divorce, losing a loved one. People see it like they are normal events and you are not supposed to get a condition because of it. So if you go to hospital and say, I am sick because I have lost my husband or we broke up with my boyfriend, how will people take it? So another reason is the symptoms usually start from mild, now graduating to severe. So people tend to assume that the symptoms will go away by themselves. So they give it time to clear by themselves. Yeah. Back to you.
Thank you. Yeah, so basically so people would think if I come out clean, I have depression. This is what I'm feeling. So what will people think about me? If I come out clean, I have a mental health illness. Will I get a boyfriend? Such things. So in the community, the stigma is there. Like here, I don't know about other countries. You'll find that here in Kenya, stigma is there around mental health. So this person is going to see a psychiatrist, this person is seeing a psychologist. So that person has an issue, and you'll find out they're not accepted in the community, okay, the way that maybe they would want to. So most people will lock their doors, hide themselves in their room, because they wouldn't want to be judged. Other people will associate mental illness with substance abuse. So people out there will say he or she is sick because he was abusing drugs, he was abusing marijuana, he was using alcohol, that is why he's like that. So I find out most people will not come out because of such reasons. What will people say about me? Yeah, so what are the different types of treatment for depression? Anyone would want to start?
Generally, we know that CBT works really well for depression, but I don't necessarily think that's the case for every single client. With the range of different therapeutic approaches we have to depression, I really think it's client specific. But like I said, CBT seems to work well. I also realize that in the area where we live, there's a lot of people who have a spiritual life, and so it's really important to include their spirituality when it comes to depression, so that you're dealing with them holistically rather than just from a psychological point of view only. I think it's important that we, and I've noticed this in my work, that we look at a client holistically, we do our part, but then we refer to the necessary other medical practitioners, whether that's a dentist for the sake of their teeth giving them problems, or a doctor for another health condition, or a psychiatrist. So to work holistically, but from our point of view as psychologists, I think it would be CBT, but then again, to recognize that we can't use a blanket approach. It's got to be client specific.
Thank you. Thank you. Anyone who also wants to contribute? V?
Also, also in psychology, interpersonal psychotherapy, I think it's one of the best for depression, because it looks on all the 4 areas of, I can say, causes of depression. Actually, but we must always remember that depending with the severity of depression, we must assess if there is need for medical backup also. Back to you.
Thank you. Josephine, would you want to go? Different types of treatment?
I only have experience of cognitive therapy.
Okay.
But I know that there is counseling for depression, EMDR, but I think it's really important that it is client-centered and person-focused, and it needs to be what works for the individual.
Thank you. Thank you, Josephine.
Yeah, I think we could also try the dialectical behavior therapy for depression. And basically all the techniques that come with the psychotherapy. And like, I think it is Sandra, I don't know who talked about medication. And if cases are more severe, then we can always involve a psychiatrist for prescription. Yeah.
Thank you. So we find most of our clients with suicidal thoughts, ideation, and others can go as far as attempt. So could depression be the only cause of suicidal ideation or thoughts? Is there anything else that can cause the suicidal thoughts and ideation?
I I can say that depression is not a major contributor to suicide, unlike schizophrenia. Schizophrenia is the identity for suicide.
Okay.
Yeah.
All right. So, Celeste, would you want to give your contribution about suicide and depression?
Well, I think it's not always necessary, or it's not always presented when there's depression. It's not the only thing. We sometimes have isolated cases of people feeling suicidal when there's been an event, if that makes sense. So they haven't even been depressed, but something's gone wrong. So a relationship's ended, and straight away they want to commit suicide. I think that may be a reverse of how we generally see suicidal ideation, because generally I think what happens is somebody's depressed or struggling with some other mental illness, whether it's schizophrenia, anxiety, a personality disorder, and then the suicidal ideation comes. But there are events where it's the other way around, that the person first wants, like they get suicidal straight away after the event, and then the mental health condition deteriorates and they end up with a mental illness. So I think that's important that we recognize that. The other thing I think as well that we've got to recognize is substance abuse. When people are coming off substances, certain drugs, and also certain prescribed medication, we've got to recognize that there's a possibility of suicidal ideation or suicide attempts. So I think that, I don't know where everyone is, but I know that one of the things that we notice here is that people only associate suicide with depression. And it's one of the things that we are trying to get away from, so that people recognize that there's, over 200 mental health diagnoses or mental illnesses that we can look at, and everyone just looks at depression. And so it's one of the things that in the work that I do, I'm trying to obviously educate the public that, look, yes, it can be depression, but it's not necessarily always the case. Somebody could be coming off a bad trip. They could have tried drugs once and they come off and they're suicidal, but there isn't necessarily a long-term mental illness.
Yeah, V, would you like to give your contribution about suicide and depression?
I think if you've had trauma in your life, that can also make you suicidal. You don't get support for it and don't have the help to work through it. And further to the substance abuse, alcohol can also be a very big factor.
Okay, thank you. Josephine?
Yeah, I just wanted to comment that we also have, individuals with the sexual deviation orientations that are made most probably from, and they're coming from very unsupportive families or hostile environment. And you'll find that such individuals could always be having the suicidal thoughts and depression that would come along. Then we also have pre-existing medical conditions that may be linked to depression. Yeah. We also have our patients who have conditions where they experience chronic pain or terminal illness, and there will always be these, suicidal thoughts and ideations. So there are other, I think it is, someone talked about underlying psychiatric disorders that maybe could also be associated with depression, and that you find them, always thinking about suicide. Yeah.
Okay, thank you, Josephine, for your contribution. Now, you find most clients, when maybe they have been diagnosed with depression, they're like, now I'll have to be in this pit, for the rest of my life. If you go ahead and prescribe drug that is by a psychiatrist, they are like, now I'll be on antidepressants for the rest of my life. Do you think that somebody can completely get out of depression? Have you had cases of clients that have come out completely of depression? They are of depression.
I've definitely had clients who come out of depression. I think we need to recognize that there's many reasons why people get depressed. If it's a situational depression, then definitely if we address the situation, I think people can come out of depression. I also think that people have come out of depression once they just start changing perspective and their thoughts. I think we know from a CBT approach that a lot of the stuff is your negative thinking. So yes, people have, but sometimes it takes longer than they would expect or would want. I think a lot of clients also sometimes want to rely on medication. And I really must be honest and say that I'm not against medication, but it's only if it's entirely necessary, because it becomes a crutch. And so the client's disempowered already because they're now relying on the medication, but they're not doing the other work. And medication is not always the case. I think we know that. Furthermore to that, I want to say that some clients, we must remember there's other comorbidities that happen with depression. And so if you're only focusing on the depression and not dealing with the other comorbidities, you may find that your success rate is a little bit low. And so if we deal with the anxiety, you may find that the person, for instance, their depression breaks. Or if you're dealing with grief, unresolved or complex grief, or a trauma, or if you get them out of a certain, like I said earlier, situation. So yes, I've definitely had clients who heal and have been, and they don't have a relapse. Because I think, like I said, it depends on what's causing the depression.
Thank you. Anyone who would want to go briefly? We are about 30 minutes in. We were supposed to do this for that minute. So anyone would want to give their experience about depression. Can somebody really get off depression completely? Briefly, please. Justin, you would want to go?
Yeah, I think depending on the causes, like the lady on the background has spoken, depending on the causes of depression, then it will definitely be cured, whether they are biological causes or genetic or environmental. Then the depression can be cured, and it also depends on the willpower of the client and their cooperation during treatment. Because what I've seen happen is, when you start treatment for these patients and they start getting well, after first couple of weeks, they don't continue. There is a lack of adherence to treatment. So then it becomes a problem. So it will depend on the willpower, the support from the family, and the causes that got this person into depression. So yes, it can be cured, but it is actually work. It is work.
Thank you.
And it needs the cooperation between the therapist or the psychologist and the client.
Thank you. Anyone else would want to go? Please.
I can say for those with family history of depression, it easily reoccurs. It's difficult to treat it completely. Other causes for other causes, they can be easily cured. But for those with family history, it's difficult.
Thank you.
That's it.
Thank you. V, would you want to go?
With the team that I work in, because the team is quite short term, we have about 6 to 8 sessions with them, and then we've got the option to refer them to a team that is more in depth. So I've definitely seen cases that have recovered. But for them as well, if something happens in their life that has nothing to do with why they were depressed in the first place, we do find them come back for more CBT on that life event to cope with that. So they can definitely get past it, but might need little boosters.
Yeah, thank you. Thank you very much. I feel like we would need more time or another session to talk about depression. It's so common, so people have a lot to share, but this was strictly 30 minutes. So thank you. Thank you very much for joining today's meet. It was great to see all of you. Thank you for joining. Now, if you would allow me, I would want to end today's meet. So until next time, bye-bye.
Bye. Thank you.
Thank you.